For once, I hit the recording before I started speaking, so instead of midway through our call. Welcome, everyone. Thanks for getting on the It's Your Call. Certainly this is going to be a hot issue and hot topic for us. Today's call will impact all of us, and it's critically important to the field, to NCSD organizationally, and to DSTDP. Bill could not be on the call today. He is actually traveling out west, but he certainly wanted to stress that this was and continues to be a forefront issue for NCSD, and we want to thank Dan Daltry and the Program Operations Work Group, the NCSD Board, and the larger membership for leading this effort with CDC and ensuring that the field has a significant voice in the development of meaningful performance measures, and certainly performance measures that reflect your programs. You all know that we were involved early on with DSTDP so that the membership could have an opportunity to develop and provide feedback on national performance measures as it relates to the STD-AAPPS grant. And this is one of those opportunities. We are going to hear some initial thoughts on where we're going with national performance measures, and then we can begin a larger discussion with the full group. For those of you who are new to the It's Your Call format, this is a conference call. We don't have any slides. We have a speaker provide an update or overview of whatever the topic is, and then we open up the lines for comments and discussion. Today, Daniel Daltry, who is the HIV, STD, and Hepatitis Program Chief in Vermont, is going to give us an update of where we are in the development of national performance measures. Daniel sits on the NCSD Board of Directors, and he has led our Program Operations Work Group for a number of years. I ask that you please keep your phones on mute using *6. Let me say that one more time. I ask that you please keep your phones on mute using *6 unless you are speaking. And also, please refrain from putting your phone on hold, because you know many times there's some background music and that's kind of distracting. Also, if you could please hold your comments and your questions for the larger discussion after Daniel completes the update. This call is being recorded, as I'm sure you heard. It's being recorded. Try to keep your phones on mute. And when we open up, after Daniel gives the overview, feel free to go ahead and use the *7 or whatever to unmute your lines. And at this time, I'm going to turn it over to Daniel. Let me also say very quickly is that after the call, I'm going to send out a survey. It's only going to be like a 7-minute survey. You'll also get one from ReadyTalk, but I'm not as concerned with that as I am the one that will come from me. Please, we encourage you to please fill that out, because that's going to give us some additional information and insight as we move forward with performance measures development. So now I'm going to turn it over to Daniel.
Great. Thank you very much, Dana, and thank you all for participating in the call today. Certainly, we know that this is a significant issue. We've had maybe a year or so of rest from national performance measures, though we might have our own measures in place in-house. Things are being ramped up once again, trying to get back on track with the appropriate measures in place that align themselves with our new FOA STD-AAPPS. So certainly this is a significant time. Your input from the field is critical. I hope today, for some of you that know me, I tend to be a little long-winded. I'm going to try to keep it brief. I want to try to make sure that for the hour that we have, I get through the scale and scope of what we covered in Atlanta, but also to make sure that we have at least 30 minutes, if not more, of time for questions and answers and feedback that you guys have. This is, once again, just the beginning of the process. Your feedback is paramount. Your inclusion, CDC wants to hear from us. They've been given a tight timeline on this. Ideally, performance measures, and I'll mention this again in the next step section or what's ahead, but ultimately performance measures need to be in place and out and into the field by June. And hopefully, if all goes right, we'll be able to announce the measures at our STD prevention conference in June in Atlanta. So a lot of work is happening. These things are moving fast. Your input and feedback is critical. And please keep in mind, whatever you hear today, this is all a part of a evolutionary process. It's iterative in nature. We certainly want to have your feedback, and CDC wants to hear it from you. So please be aware of all those things. So once again, my name is Daniel. I am really happy to be a part of both NCSD and the Program Operations Work Group. I've been with the group since 2006. I've done a couple of tours of duty, what it feels like, in terms of development of performance measures. I'm excited to be a part of this new round as they're kicking out from FRESH, and we're trying to create the right measures that align with, once again, STD-AAPPS. The first thing that I would just highlight is that also when we're looking at these measures, we're trying to move away from the term performance measures and try to think of these more in terms of accountability measures. When we're looking at the scope and scale of STD-AAPPS, it is pretty targeted and directive, unlike any STD application that I've been through before, and maybe like you've been through before as well. Given that the new STD application is rather directive in terms of scope and scale, the activities that are stated in STD-AAPPS, that's what we're trying to get at with these accountability measures. How well are you covering the required activities that are recommended by STD-AAPPS? So in essence, what I want to bring home there, the effort by CDC is trying to make sure that we're not creating new work off of new work. Simply, we've been given the new guidance of STD-AAPPS in the activities that are required. Now we want to create some accountability measures that try to capture to what degree you are performing, sorry, I used that word, achieving the said activity as a part of STD-AAPPS. So just to begin, there was a stakeholders meeting that happened in December with the CDC. There was representation from all around the country. Myself, Dr. Heidi Bauer from California, Charlie Rabins, who is a consultant to NCSD, was present. Jeff Hitt from Louisiana was there. Beth Butler from Pennsylvania, and I really hope that I'm not leaving anyone else out there. It was a grand round robin of folks from the field, and I think from different morbidity sizes and areas there to hear the feedback and to give presentation. Prior to going to this meeting, we were given homework assignments. Yep, homework. And in that homework, what we needed to begin to look at were the strategies that were in place and the required activities. We were each given a certain domain. There are 8 different activity areas that are required in STD-AAPPS. We began to form and fashion measures around 7 of the 8 activity areas. The area that I believe was left off in terms of trying to frame some measures around was policy. I might have that wrong, but regardless, what I'm going to try to cover with you today are the areas that we covered. What I want to say also about the measures in terms of scope and scale, they want to begin with a small set of measures. In the past, we had an agreement with CDC that there would be no more than 20 measures. Some of the measures had measures within themselves. The tacit agreement is we want to start small with these, and of the measures that you'll see that ultimately come out, you might not be able to collect information right out of the gates on those measures. These measures that come out are things that we want to try to build to. So the first year that the measure comes out, maybe only 23 project areas are able to report on, right? The hope is that at the completion of this grant, all project areas would be able to report on the said measures that come out.
Is there a webinar too?
So once again, what I want to begin with is just the themes, that there are limits thought in terms of these measures that are coming out. The measures in and of themselves are aimed to be conservative. They're meant to be flexible, and they're meant to evolve over time. And again, it's to be something that is created in terms of partnership between the field and CDC. The program strategies that we looked at as a group, number 1 was the area of increasing chlamydia screening rates among young females 15 to 24 seen in Medicaid programs and in Title X and other family planning clinics using chlamydia HEDIS measure. So The next area that we looked at was provide assistance to nonprofit organizations that have demonstrated their ability to provide such safety net STD clinical prevention services. Assistance could be used to screen and treat women and their partners for chlamydia and gonorrhea to prevent infertility. The next program strategy that we focused on was increase syphilis and rectal GC screening rates among MSMs seen in high-volume HIV care settings. The next domain or strategy was increasing the proportion of patients with gonorrhea that are correctly treated according to current CDC guidelines in areas of high gonorrhea morbidity. The next four are increase the provision of targeted and effective health department DIS partner services for primary and secondary syphilis, HIV co-infected with gonorrhea and syphilis, gonorrhea cases with possible treatment failure or suspected probable cephalosporin-resistant gonorrhea. The next area is link to care for those partners who have not been diagnosed or previously with HIV or who test positive for HIV. And then the final strategy to be considered, for which we tried to create measures around, was the collaboration with organizations to implement STD health promotion and prevention activities for safety net or other clinical providers who seek to serve at-risk patients. So it's kind of a ambitious frontier, but again, we were teamed up and tasked with homework prior and began to look at measures that could form under those areas. Under that, we had to do not just write a measure and then go into the group and hopefully vote upon it. We had to create a suggested accountability measure. From the suggested accountability measure, we need to look at feasibility, ability to collect the data, ease of collecting the data, the meaningfulness, the potential barriers or limitations of said data. I won't go through it exhaustively. What I want to highlight is any measure that we put forth as a part of our homework project, we also had to go through a lens of filtering about how this will work, why might it not work, what the pros and cons of it might be. All right? For anyone that's looking in this call to get the exact language of what the measures will be, I hate to disappoint you, we do not have the exact language. What I will be able to read off to you now in the next 15 minutes going through those 7 activities, I am going to read with you the selected ideas for strategies that would be used, suggested accountability measures that would be used to assure the activity is being met. So again, the language isn't necessarily there, but this gives you an idea of what the language might look like, okay? So the first area that we had talked about, screening for chlamydia among young women. The goal, the activity required by STD-AAPPS, again, is increased screening for chlamydia among sexually active young women seen in Medicaid and by Title X with other family planning providers. So part of the accountability measures that could happen or could come out of this, one is looking at the HEDIS measure of screening and getting your Medicaid participants or your funded family planning providers to report to you how well both Medicaid and family planning is screening or adhering to the HEDIS measure. This measure in and of itself, I think, highlights areas in which we might have measures that we might not have control, but we want to continue to monitor because we as a program may have influence. Additionally, off this measure, we don't want to just see screening for screening's sake. Other assurance activities that could come out of this, or a measure that could come out of this, is a measure around the positivity, a prevalence monitoring, and then possibly a process measure around the treatment that's reported among these individuals within 14 days and 30 days. All right? The next area that we looked at is assistance to NPOs, nonprofit organizations, and the activity is provide assistance to NPOs, nonprofit organizations, that have demonstrated their ability to provide such safety net STD clinical prevention services. This one was really challenging. I think that came out both in the tremendous effort that came from the field representative in trying to create measures around this, but also, too, as we went through and dialogued as a team about this. It felt as if the measures within this were more about accountability opposed to performance, and therefore didn't lend themselves necessarily well to assurance. However, the possible themes to look at in terms of assurance activities were dollars per case of chlamydia gonorrhea in women identified through screening and diagnosed / testing, percentage of those patients, women or men, screened or diagnosed for chlamydia, gonorrhea, or syphilis who were uninsured, percentage of symptomatic males with gonorrhea who received their partner's services or expedited partner therapy within 7 days. Final assurance activity area to look at with potential measure would be positivity rate, treatment rate of chlamydia and gonorrhea among organizations that provide this assistance. So this, again, it might lend itself more to accountability opposed to assurance. Not sure how actionable this will be through measures, but those were part of the themes that we looked at and tried to think about. These are the areas with that activity that we'd want measures created upon. The next one, and there was a lot of robust discussion around this, but was around the area of syphilis and rectal GC screening, particularly increased screening for syphilis and rectal GC among MSM or gay-identified males seen in high-volume HIV care settings. So just, a little editor's note here. You see in and of itself there are some things that could be limitations here. One, what kind of denominator would we be looking at here? Two, what are the providers that are going to report on this? What is their ability to report on this? Three, if we're looking, once again, at denominators and rectal gonorrhea screening, not all MSM might be rectally receptive. Not all MSM might have other partners than their main partner. Some MSM might be married. So there certainly could be some limitations to this. Also, in terms of looking at FDA practices in screening or validation of gonorrhea, it's still not FDA recommended for a rectal screen, though we have laboratories validated to do as such. FDA still hasn't provided that clearance. What might the hurdles be for provider practice to do a non-FDA approved activity, and whether or not that's reimbursable or not through insurance? There's a host of issues here. CDC is aware, and that's part of why CDC is taking all the feedback that they heard from us and will hear from you, and trying to sift it through and layer it or build it into any sort of measures that they create. The areas to look at, once again, for syphilis and rectal gonorrhea screening, the areas that might have accountability measures would be among this population, once again, gonorrhea, syphilis or gonorrhea among MSM in high-volume HIV care settings, percentage screened for syphilis, percentage screened for rectal gonorrhea, percentage of new cases for syphilis, percentage of positive for rectal gonorrhea, percentage treated within 7 to 14 days for syphilis, percentage treated within 7 to 14 days for gonorrhea. Systems measures of where screening and treatment for syphilis and rectal gonorrhea occur for this population, example, at an HIV care setting or at other clinical settings. So keep in mind, not all in HIV care, not everyone, not in an HIV care setting, not all males also are MSM. So a lot to think about here. Certainly the CDC heard it, and we'll try to factor it in, and maybe we can have a further discussion on this area today to try to gain some clarity. The next, we only have 3 more areas to cover, and then I can open up the lines to you folks. The next area was gonorrhea treatment and increasing the use of appropriate treatment for gonorrhea in areas of GC high morbidity. Just a disclosure here, being Vermont, probably being one of the lowest morbidity areas. I know I can go on record as saying I'm the lowest funded area. What a distinct and dubious honor. But just want to say to other low morbidity areas, both when we look at syphilis and rectal GC screening and we look at this GC treatment measure, high morbidity size still will be applicable to us. It just might be a little bit different than what is thought about in other leading areas. So looking at GC treatment, the areas for measures were pretty straightforward. The thought is this would be a measure of one in and of itself, but the measure would flow something like this. Gonorrhea cases reported that had received recommended treatment, cases that were reported with non-recommended treatment, cases reporting with no information, meaning areas that we get cases reported, but I understand in larger morbidity areas, not all cases that are reported do come with treatment information. And granted, if you're dealing with a scale of 5,000, 8,000 cases of gonorrhea, I'm sure you're not going to go back and try to verify treatment on every said case of gonorrhea. That's just not cost effective. But then also trying to look at, of the cases reported in which there was no treatment, also documenting that as well. The thought came out here whether or not sampling or no sampling would be appropriate. I think there could be a case made for sampling. The folks in the room at the time argued against sampling, but again, that's something where the CDC certainly wants to be flexible with us and try to hear what we need from the field. The next to last area to look at, partner services. So under partner services, the activity that we're all required to do is increase the provision of targeted and effective health department DIS partner services for A, primary and secondary syphilis, B, HIV co-infected GC and syphilis cases, and C, gonorrhea cases with possible gonorrhea treatment failure or suspected probable cephalosporin-resistant gonorrhea. Editor's note here, I totally appreciate. Some areas certainly find value and will continue to run early latent cases, and maybe that's something that needs to be included up in this measure as well. Again, we need to look at this and realize this is a part of a body of work. If you feel strongly that ELs need to be included with the PNS, please put that forward in this period in which there's open comments, both on this call but also to your program consultant or when CDC solicits feedback formally. The areas in which we would try to look at measures or try to create a measure around would be percentage of partners or PNS syphilis tested for syphilis, percentage of partners to primary and secondary syphilis who were brought to treatment as in newly identified, and next, percentage of partners to primary and secondary syphilis that were prophylactically treated for syphilis or co-infected. The next, looking at co-infection with this, the measures would be percentage of persons diagnosed with gonorrhea or syphilis who were also diagnosed with HIV. A little bit different here, the following measures, but the following measures would be looking for numerics. Number of partners to an STD case that were newly identified for HIV, number of gonorrhea cases identified via partner services for gonorrhea HIV co-infected persons, number of HIV cases identified via partner services for gonorrhea HIV co-infected persons, number of syphilis cases identified via partner services for syphilis HIV co-infected persons, and the final area would be number of HIV cases identified via partner services for syphilis HIV co-infected persons. Part of the logic of shifting to numbers here, if you guys have never heard of the STIC figure or the STIC formula, it's trying to look at cost effectiveness of prevention services. I think the logic goes as, you find X amount of new infection, it goes to ultimately verify the expenses that you're paying, i.e., you find one new individual that's HIV positive through your service, you're potentially saving a cost of $497,000 across the lifeline if you're preventing yet another infection of HIV. So part of the thought or shift here to numerator is to look at a cost-value sort of operation. The next area that we covered, and we're rounding home here, folks, so get ready to have at it. But the next area to look at was linkage to care. And again, we're going more with a HRSA definition here in terms of individuals that are linked to care are said to be individuals that have received medical services within 90 days of diagnosis and that have had 2 or more laboratory values in the course of 12 months. But the areas that would be actionable here would be looking at percentage of partners who were newly diagnosed with HIV and who have completed a medical visit for HIV within 90 days to test. And the evidence or verification for that would be a viral load or a CD4. Next would be percentage of partners referred versus linked and what the fallout is there and what we might see. The final area that we looked at as a group was provider-focused outreach. And the activity is collaborate with other organizations, again, Npos, nonprofit organizations, that implement STD health promotion and prevention activities for safety net or other clinical providers who seek or see at-risk patients. The 3 short areas that we looked at: number of MOUs or other measures of partnerships between health departments and provider organizations or practices, screening rates among providers receiving health department or prevention education dollars, and treatment rates among providers receiving both HP or PE. So if this past 25 minutes seems kind of exhaustive to you, trust me, it was a fun-filled day and a half in which we tried to cover all of these things. This was an extensive process, a lot of dialogue. They were long days. We did a voting process around it. And now begins the phase or next steps that will happen with these measures. As a part of these next steps, for folks that were able to make the kickoff call and heard the wise words of Dane Collins, you might have remembered towards the end of that presentation, he had a chance to go through the timeline, laying out what happened in December, what happened in January. What's ahead for us or on tap for February is a continued feedback and pilot of performance measures that are drafted by DSTD leadership in a review for approval, a plan for measure feasibility pilot through STD. DSTDP will review of reporting requirement systems, assess project area issues, possibly looking at a reporting repository such as EvalWeb. And I understand some folks love EvalWeb, myself being one of them, but I also some folks, and I heard this at our NCSD conference, loathe EvalWeb. So certainly that's there, but trying to find the right reporting mechanism for said measures. Also in February, there'll be the plan to introduce the measures for feasibility pilot on a webinar hosted by CDC late February. The date is to be determined. And then there'll be a commencing effort between both NCSD and DSTDP on the development of the measures in February. March will see us conducting the feasibility pilot with representative sample of project areas. So that means the measures will go out to targeted areas, but across the incidence lines, high, low, and medium, everyone in between. But we want to make sure that these measures stick and can work for all or say something to all. Because again, these measures that we want to have, we want them to be actionable. We want them to have teeth and help managers to guide their programs. April of 2014, we'll see a review of that feasibility pilot results. Next, DSTDP will approve the final measures and reporting requirements. A webinar will be conducted to project areas to present the final measures and reporting requirements. There'll be a continued dialogue between NCSD and DSTDP, and if necessary, create an OMB package for clearance. May 2014, complete the process measure development, and those will be vetted to project areas, open for comment period. Once again, if I haven't highlighted this already, and I think I have been remiss in doing this, these measures that I have read to you are all about outcomes and accountability. But CDC also appreciates the importance of having process measures in place. NCSD, via the Performance Operation Work Group, will be trying to lead the charge in presenting to the CDC performance-based or process-based measures. If you have something in your pocket that's working well for your program, please kick it to me and the POW as something you want to see vetted and to go up the chain to CDC for inclusion as a formal process measure. Okay? So that's a little plug for POW, and it's a little plug for you to share your wisdom with all. Please do so. June 2014, there'll be a grand unveiling and hopefully an open bar. No, I didn't say that. After, but it will be a launch of the national measures and associated with process measures at the STD conference or grantee meeting that occurs. So, again, folks, this is fierce, this is ambitious, it's moving fast, but all words and feedback is important as you have it, so that we can try to get meaningful measures in place that speak to our programs and that can evolve themselves over the course of this grant. Measures are critical in terms of justifying our funding. Measures are critical in terms, as you know, of guiding our programs, where we're at, what we need to be doing, and what we can be doing better. In terms of next steps, I also want to let you know, notes from the meeting that we had in Atlanta will be disseminated to you all. NCSD will be working and figuring out the best mechanism to get that out to you all. So you will have a clearer understanding than what I just presented here today. So having been through all of that, I hope I was trying to be as concise as possible, yet comprehensive.
The conference has been unmuted.
Open up the lines and see what folks have to say in terms of questions, thoughts, concerns, acknowledgments, anything.
Great. Thanks, Daniel. That was certainly a lot of information for folks, but hopefully everyone has digested some of that and is ready to make some comments or have any questions.
Can you hear me?
We can. Questions and comments for Daniel? So Daniel, as people are thinking about and digesting this stuff, let me just ask you, what talk is there about previous measures that may have been working and you all had mechanisms around reporting on them? Are they going to be included or looked at for the new performance measures or accountability measures?
Yep. Thank you for that, Dana. And certainly, when we are looking at these measures, there were systems that were built up around other measures, and the CDC certainly does not want to my understanding was the CDC did not want to throw out what was working and what programs had built. In terms of looking at future program outcome measures, the CDC would want to have in place things that are meaningful, that are actionable, that truly show some sort of outcome in terms of driving down disease. Unfortunately, some of the measures that we had in place or that we had of old didn't necessarily lend themselves to showing an impact on overall incidence or morbidity. So it is a way of saying some measures absolutely will be entertained for being kept, but as a whole, all those measures won't stay in place. And that is a challenge. I totally appreciate that. But again, what the CDC wants us to try to look at are what are some program outcome measures that we can have in place that really show to be drivers or have impacts on the various activities that we're now required to do. If there were measures of old that you really do feel have an impact on the morbidity or incidence happening in your area, that is something that we need to hear from the field about which measure you feel needs to be kept, as it truly, whether it achieves a program lends itself well to a program outcome measure, or whether it lends itself well to a program process measure. We need to hear that from you. So I think they are open to keeping some, but certainly not all.
Okay, that's good to know. Thanks. Other questions for Daniel? I have opened up the lines, but if you're not going to use your line open, please just *6 it to mute it.
Hi, this is Tricia Mason in New Jersey. Can you hear me?
Indeed.
Hi, I have a question. I was listening to everything that you were saying. Now, some of these measures that you mentioned, like for instance the anal swabs.
Yep.
And also, working with nonprofit or CBO,
yep,
and so forth. Often when you're working with outside agencies and you're asking them to provide you with information and to work with you on certain objectives, it's always good to be able to help them fund the additional work that we're asking them to do. Now, if we go ahead and pick up one of those measures, which I think they're really good measures, it's difficult to tell how people are going to react to that, or how they're going to work with us, because often, especially in New Jersey where I am, most of what we do is through negotiation with other people, because we really don't have funding to pay for some of these things. Now, if you pick up a measure and you're not able to deliver, let me put it that way, you don't get the cooperation you thought you would,
yep,
how would that work? I mean, would that end up working against you?
Sure. And so I hear a couple of things in there. Let me try to go at a couple of them. First of all, and you hit right at the core, Patricia, of the tension that is there, and something that I tried to mention in the beginning of this as well. When we're looking at these program outcome measures, some of them are going to be things that we directly fund and can ask our recipients to report on this, i.e., Planned Parenthood, that's the Title X provider here in Vermont. I am going to give you X award. With that award, I want you to be reporting on, in accordance with the HEDIS measure, the number of women 24 and younger that are screened at least annually for chlamydia.
Exactly.
Very easy to leverage.
Right.
Got it. It's a part of my grant. You're getting funds. This is a data point that I want to have.
Exactly.
Then we go to something like HIV Care Settings,
Yep.
And I realize, in Vermont, we have one entity that's providing care to over 83% of the individuals living with HIV. That is not the story in Jersey. So, so yeah, it's great that in Vermont I can write into their grant if they're in agreement, and that's another issue too, because we've got to make sure that these community partners are in agreement with the measure that's out there.
Exactly.
We can present to them. CDC says that it's the best practice. We could highlight for them the, I think, staggering information that California presented, CSD's annual meeting, about the importance of pharyngeal or rectal swabs and gonorrhea identification. But at the end of the day, we're dependent upon provider practice.
Right.
And it is going to be a challenge.
Because, you ask people to do things, and you have a meeting with them, and they're in agreement. And then they end up getting cut, their funding get cut, personnel get cut, and then you run into a problem because they can't meet your standards and you can't help them because you have nothing to give them.
Yeah. I think, and it is challenging, especially too, you know, they're getting cut, we're asking for reports, please give us reports.
Mm-hmm.
But I think part of what we need to do too, as, you know, this goes back to the issue of influence, because we can't necessarily hold them accountable if we're not funding them, but we try to influence the outcomes by saying,
we do a lot of that in New Jersey. That's
good.
all we have.
Sorry? Yeah. This, I've got to tell you, you know, I know you want to provide the best care for your, this is where we got to be a bit of a salesperson, you know.
Right.
You want to provide the best care that you can to your patients. What I am telling you is disproportionately women 24 and younger are being impacted by chlamydia. I can show you the data. I can show you that since the past 15 years, 70% or greater of our population's been 24 or younger with chlamydia.
Mm-hmm.
Treat it now, you prevent infertility later.
And that's what we do in New Jersey. We're not in charge of these programs.
Yeah.
And so everything that we do is through collaboration.
Yeah.
Okay? And so we do a lot of that.
Yep.
You know, the only problem is when things are written into measures and the expectations are there, and then you think everything is going well, and immediately, you know, somebody gets defunded or they get cut or, you know, whatever the case may be, then you're left up a tree.
Sure, sure. And I think, but Patricia, your question though goes further, and it goes to what you're saying. I think where you're leaving off right here. So, not just, you know, how are these measures actionable out in the field, but how are they going to be actionable back on us? And that brings to the question about benchmarks. You know, and with the last set of performance measures that we had, we never hit upon benchmarks. We never got there. But also, what will the repercussions be if we're not performing at a certain level on certain measures?
Exactly.
All that I can say to you is that, you know, I think as these measures are rolled out, and what I think what we'd all like to see, and hopefully what POW and from the field would champion to CDC, is that certainly certain measures can come with benchmarks. There's other measures that might not be able to come with benchmarks. You know, the last set of ones that we were looking at, you know, in terms of screening within juvenile detention facilities, you know, we, with the minimum award that we had here in Vermont, there was no funds left over at the end of the day to award out to our one juvenile detention facility. What if they said 70% of new enrolled folks need to be screened for chlamydia? How am I? And then that comes back and gets measured against me. I don't have funds for it.
Right.
That institution's not going to be able to do it. So the quick answer here, I think, and something that we're all going to need to make sure we pay attention to, and I think the CDC is open to it, certainly some program outcome measures will be able to have benchmarks, and there'll be an expectation on certain standards, but there will be some that can't, you know, or you put it out there, but it has to be one of those things that doesn't have a consequence back on the project area in their funding.
Okay.
So I think they get that tension. Certainly we would continue to advocate that as well. I think there are some measures that are core, you know,
Right.
But there are others that we need to be careful. Yes, set a bar, but also realize that's a goal, and we might not all be able to achieve that goal.
Thank you.
Yep.
Thanks, Tricia. That was a great question that sort of answered a lot of other questions I'm sure people have. Others, questions or comments?
Hi, I'm Patrick Dwyer from the New Jersey Department of Health. Hello?
Yep.
Yes. My question is, has there been any thought given to how as the ACA rolls out, how it will affect the reporting of disease and measures like what you're describing?
Yes, and absolutely. We talked about that, or we hit upon that in two different areas. One was looking at, especially when we were looking at the measures related to men who have sex with men. It's my understanding as a part of ELRs, sexual orientation isn't even a part of the mandated reporting. With ACA and ELRs, you know, there's going to be the meaningful use incentive. but we might not be getting all of the data points that we need with certain measures. But it was also, when we look at a measure such as the HEDIS measure, I think that, Patrick, hits right upon something that we're trying to factor in with these measures. How do we capitalize upon the benefits that are coming with healthcare reform, and how do we use them, to our advantage? How do we capitalize on the opportunity that's afforded to our consumers where there might have been barriers in the past? Now we can leverage it as a resource for them to access vital services, safety net services. So I think what you could see is a clear link to trying to capitalize upon ACA when we look at the HEDIS measure and the percentage of screened among the Medicaid population.
Okay. There may also be other things, I would think, too.
Absolutely. And I think NCSE certainly has been watching this. They've held a couple of webinars on this as well. This goes beyond, I think, both program outcome and process measures, but also looking at generation of revenue. NCSE has created a pretty elaborate third-party billing guidance and clearance on us. I think we have an amazing model that's been presented by Oregon as well. ACA, I think, opens up a lot of doors, and it also suggests, just as you said, as that moves along and gets rolled out in further areas, an opportunity for future measures to be created. And it's something I think we've got to do. The biggest talk in our world has always been integration between TB, hepatitis, HIV, and STD. The 3.0 or 4.0 version of integration is probably going to be looking at ACA and how it speaks to your public health STD program.
Daniel, it's Lori Copps
Hey.
From Montana, and have HEDIS measures in Montana.
Yeah.
And so gathering that Medicaid data is well, I don't even know what it's going to look like yet, but just in discussions, it's relatively complicated. Well, far more complicated than if we did have a HEDIS measure. So, what if there are performance measures that we actually can't live up to because our state doesn't collect certain data that we need to have to report out?
Yep. And so, Lori, what I would say to that is it might not be now, but hopefully it's something for later. Hopefully, if we look at one of the ones that I'm hearing a lot of feedback on right now is the HEDIS measure. Some areas saying, I'm not equipped, I'm not even at the table, they won't even let me in the door. This is being recorded, so I'm using the safe words. But I think it's something like this. If we lay out a measure such as this, it builds the ability for you to go back. We might not be a priority right now with everything that's happening with ACA. They might have their hands a little bit busy with other concerns. Our grant is a 5-year grant. We have it built into our grant that this is a requirement, some activity that we need to look at. Hopefully we can use that requirement as a bit of leveraging with our Medicaid partners to let us in the door, to let us measure. It's in both of our interests to have that measure reported out to us. They want to serve their population holistically and comprehensively. We want to ensure that we are making sure that our at-risk populations are less at risk for certain infections. So, it's one of those things. It might not be now. It might be down the road for later. Hopefully it will be for later. Hopefully this is something that's not actionable back at you as a program. But it's something I think we all need to look at. How do we capitalize on the different opportunities that are afforded through ACA? And hopefully this measure, even if you can't report on it now, hopefully it's something, at least a talking piece or a leverage piece that can get the conversation going between you and your Medicaid counterpart.
Thank you, and I also want to thank you for being the voice for all of us. And I know that there were others that worked with you, but you seem to be ahead of the pack, and I just really appreciate all the time and effort and work and understanding that you've put into this, because it certainly makes it better for the rest of us. Thanks.
Thank you, Lori. Thank you a lot.
Daniel, this is Bernard from South Carolina.
Hey, Bernard.
Hey. Is there any thought to, beyond the overarching accountability measure here, that there will be an opportunity for drill-down measures that are guided by local morbidities within the states.
Yes, yes, absolutely. And that's part of what we're trying to look at in terms of measures, and that might come in more under program process measures. But trying to look at measures that can go to scale, not just on a national level, but we need measures that speak to state, and we need measures that speak to jurisdiction. So that's definitely what we want to have. Maybe different in the past. What we would have is that, let's say, just to give you a picture, 5 core measures that speak on a national level. Then you would have a chance to pull from 5 elective program process measures. And those might be measures that speak from a statewide planning. Those might be measures that speak to a jurisdictional level planning for you. So with those 5 remaining measures, you could choose 3 that speak to the state, 2 that speak to the jurisdiction, or you might say, bunk that, I'm just going to do all jurisdictional measures. But I think part of the aim is to try to have a core set of measures and then an elective body of measures that you could choose from on your own. Again, they'll have a bit of national reach, but it's for you to apply to how it fits for your jurisdiction.
Okay.
And I think that's going to be tricky, trying to get things that speak across jurisdictions on a national level. But certainly that's what we want to entertain. And Bernard, please, if you or others on this line that have measures, process measures that are working for you on a state or jurisdictional level, kick them my way or send them to Dana or anyone at NCSD. Let's get those measures in place. Let's look at them, and let's present them to CDC. Please.
This is Sue Blank in New York.
Hi.
Hi. Listen, one of my questions is, so we're putting in an awful lot of effort into coming up with performance measures, and from what you've mentioned, not a single one of them addresses congenital syphilis.
Mm-hmm.
And yet that is one of 4 priorities that we have. It's sort of remarkable. Yeah, you're not expected to have an answer, but it is sort of remarkable that it's a priority area and a winnable battle, and there's nothing there.
Yeah, I don't think there's anything I can touch with that. You've said it yourself.
Although that's actually like one of the few things that we can, in fact, prevent.
Yep. And I just the color commentary that I would add is simply, I think we've all heard Dr. Boland say this. On any level, a case of congenital syphilis is a public health failure. That those are very strong words, but I think what she's trying to say is that this should always be at the core of our measures, maybe even without in writing, but what I hear from you is certainly we need to have a measure on congenital syphilis.
Yeah, and I think actually, again, it is one of the few measurable outcomes where we actually have prevention tools.
Yep.
And so in that sense, it is in fact, I think, sort of from a strategic point of view, it lends itself better to outcome measures.
Absolutely.
Any last questions or comments for Daniel?
This is Bernard. Just one about the congenital syphilis measure that's just spoken about. Congenital syphilis really impacts a small part of the nation as far as being I don't want to say a real problem, but most of the congenital syphilis comes from a small cluster of states and jurisdictions. So to make it a national funding-wide kind of initiative might leave some areas out of the capacity to report and engage in that, plus the fact that I think congenital syphilis is tricky in that you can't require somebody to get prenatal care. And at the point of labor and delivery, whatever is happening has already happened for the most part. You can give medication and you can identify cases, but all during the time that the baby's being carried, that's already happened. So I'm okay with leaving that one kind of on the sideline as a major, but that's why I asked the question about the drill down areas that congenital syphilis is a problem. You could stick it in the PNS, partner notification, or you could stick it somewhere else to say, okay, if you're in an area, then you need to do this additional thing.
Thanks, Bernard. Last comments or questions for Daniel?
Yes. Hi, this is Tariq Mikari from Chicago, Department of Health. The question I have is I just want to know, was EPT mentioned in any of the performance measures?
We did bring up EPT. There was a concern about how we would be able to measure it, but absolutely, that's maybe one of those measures, as Bernard took us to, that we need to elect into. EPT was talked about. We had nothing really that rose to the level, but there was a request and ask to have an inclusion on EPT.
Thank you.
Yeah, and that would be another example. EPT is going to be not allowed in South Carolina no matter what. It's legally prohibited. We're not going to get beyond that barrier in the next 5 years. Carolina's just so stupid about that.
And I don't think that's just a South Carolina issue either.
This is Allison Muse from New York State. Since we're so close to the end of the call, is there another process for submitting questions or comments that we might use?
Well, Allison, right after this call, I'm going to send out a survey that's going to have some questions, and you can provide some comments and feedback on that. We encourage you to do that.
And I just want to thank you all today for taking the time, sifting through this. I realize when I read, it's a lot of information. I'm not sure how much you were able to glean from what I was saying. NCSD will be sending out notes of, this meeting or the recording will be available, but I also want to let you know that there are notes available from the December meeting, and they will be distributing them to you in some capacity in the coming weeks, so hopefully this will be clearer. Please sift through this, give feedback as you can. We're only at the beginning here, but the ending isn't too far away either, so your feedback is critical and will help us to have the best measures we can in place. So please take some time. I know time is precious, but take some time because these are the measures we're going to have to live with.
Thank you, Daniel. Thank you so much, Daniel, for a great update. I mean, that was very informative, and we really thank you. Those on the call, this is being recorded, and we will have this recording up on our website sometime next week. Thank you for your participation, and please fill out our survey. Thank you.
Thank you. Please stand by.